Greetings, ladies and gentlemen. I am Brian MacArthur, the Acting Deputy Vice-Chancellor and Head of the College of Law and Management Studies. It is an honor for me to welcome you to the inaugural lecture of my colleague, Professor Kaymarlin Govender. I have had the pleasure and privilege of working with Professor Govender as the Director of our Health Economics and HIV and AIDS Research Division in the College, so I am delighted to be part of this auspicious occasion. Our Vice-Chancellor and Principal, Professor Nanapoku, extends his sincere apologies for being unavailable today. He conveys his congratulations to Professor Govender and his regards to Professor Govender's well-wishers in attendance. It is also my pleasure to welcome our esteemed guests, members of the executive management, members of Senate, staff, students, and alumni, distinguished guests, importantly, our inaugurand this afternoon, Professor Kaymarlin Govender, to whom we extend our heartiest congratulations. Also, the family, colleagues, and friends of Professor Govender. In particular, Professor Govender acknowledges his partner, Shakila Govender, and children, Tayur, Sana, and Arzan, for their unwavering support. A special thank you to his mom, Mrs. S.R. Govender, and late dad, Mr. J. Govender, for their guidance and support, providing a firm foundation in his academic journey and social activism. Colleagues and friends within and outside the university who have sustained, encouraged, and celebrated his achievements along the way. Ladies and gentlemen, inaugural lectures form part of the university's public lecture series and may only be presented by newly appointed full professors, and they celebrate the attainment of the pinnacle of an academic career. These lectures present an opportunity for showcasing the exciting and groundbreaking research and teaching being carried out by professors in our university, and are a significant milestone in an academic's career, providing official recognition of their promotion or appointment to full professorship. These lectures are furthermore an ideal opportunity for new professors to introduce themselves and to present an overview of their own contribution to their field, to academic peers, students, and research collaborators. Inaugural lectures are also a platform for celebrating a professor's academic achievements with his family, friends, mentors, and colleagues. Colleagues, this unprecedented time in history is characterized by exponential and disruptive change. The challenges of the global COVID-19 pandemic remain center stage, but it is imperative that we not lose sight of other global health challenges, in particular that of HIV. We salute Professor Govender for his substantial contributions in this arena. Earlier this year, I had the privilege to be a part of the virtual launch of a book titled Preventing HIV Among Young People in Southern and Eastern Africa, Emerging Evidence and Intervention Strategies. The editorial team comprised our Vice-Chancellor and Principal, Professor Nanapoku, Professor Kaymarlin Govender, as well as the interdisciplinary team of local and international contributors who produced an exceptional body of work in the area of HIV. The publication of this book remains timely as the Southern and Eastern Africa region remains the center of the HIV pandemic. My appreciation once more for joining us. I look forward to Professor Govender's presentation on HIV prevention, as the topic is highly relevant to our current circumstances. It is now my pleasure to hand over to my colleague, Professor Colette Muller, College Dean of Research and acting as Dean and Head of School in the School of Accounting, Economics and Finance, who will introduce Professor Govender more fully.
Thank you very much, Professor MacArthur. Professor Kaymarlin Govender is a behavioral scientist with more than 25 years of experience as a researcher and technical advisor on health programming in sub-Saharan Africa, with a special focus on HIV and sexual and reproductive health and rights. Since 2011, Professor Govender has been appointed as the director of HERD, the Health Economics and HIV/AIDS Research Division in the School of Accounting, Economics and Finance in the College of Law and Management Studies at the University of KwaZulu-Natal. He has worked extensively with international funding agencies and various national development agencies, including the Swedish International Development Cooperation Agency, RNE, the Department for International Development, USAID, UNICEF, CDC, the Bill and Melinda Gates Foundation, the Global Fund, the Wellcome Trust, and the SADC HIV Secretariat. He has served as a principal investigator or co-investigator on several multi-country research studies focusing on the social and behavioral aspects of HIV and led bilateral partnerships with universities and research institutions in Sweden, Norway, France, the UK, the USA, and across multiple countries in Southern Africa. Between 2014 and 2018, Professor Govender was a visiting professor at the Sahlgrenska Academy at the University of Gothenburg in Sweden. Professor Govender has also previously served as a member on South Africa's National Research Foundation's Centre of Human Excellence and Human Development, and has held several NRF grants. He has an established research record of over 130 peer-reviewed publications, with several publications in Q1 journals. His publications have received in excess of 2,000 citations. He has supervised many PhD and master's students. He was previously the convener of the third International Structural Drivers of HIV Conference, a partnership with the University of East Anglia and the London School of Hygiene and Tropical Medicine. He subsequently led 2 international special editions on the challenges of implementing HIV/AIDS programs in Eastern and Southern Africa, while serving as associate editor of the African Journal of AIDS Research. More recently, he served as co-chair of the scientific track on social drivers of the epidemic at the 9th South African AIDS Conference titled Unprecedented Innovations and Technologies, HIV and Change. He has served and currently serves on a number of regional committees and task forces on HIV and sexual reproductive health programming in the SADC and Eastern and Southern African region, including the Global Fund for HIV, TB and Malaria, UNAIDS, UNFPA, SADC and bodies in the East African community. As Professor MacArthur has already mentioned, Professor Govender's recent co-edited book is titled Preventing HIV Among Young People in Southern and Eastern Africa, Emerging Evidence and Intervention Strategies. And this book draws on research and policy analysis by international scholars in the field of HIV prevention. There is no doubt that Professor Govender is a scholar of acclaim whose research on health promotion and advocacy activities has had considerable influence at a local, national, and international level. On behalf of Professor Mabuta Sibanda, the Dean and Head of School of Accounting, Economics and Finance, who is unable to join us today, I'm delighted to introduce Professor Kaymarlin Govender and invite him to present his inaugural lecture. Thank you.
Good afternoon, colleagues, and a warm welcome, and thank you for joining me this afternoon. Thank you to Professor MacArthur and Prof. Colette Mulder for such warm words and inviting me to this lecture. I am going to share my screen and prepare the lecture for this afternoon. You would give me a second. just having issue with one of my settings on my screen to get my presenter view on. Just give me a second. Okay. I hope you can all see that. There we go. Okay, colleagues, thank you. Now that I have my screen share sorted out. My lecture this afternoon is will focus on HIV prevention amongst young people in Eastern and Southern Africa. And this work is a culmination of a number of years of research and activism in the area. And my work began in the early days of an academic in the Department of Psychology and the Health Promotion Program at the University of Durban, Westville, and then to University of KwaZulu-Natal. And over the period, I've been engaging in research projects in South Africa and in Eastern and Southern Africa, and worked with students and faculty members. And over this period, I moved on as director to the Health Economics and AIDS Research Division at UKZN, and expanded this work in the region in Eastern and Southern Africa, hence the title for this presentation. And the presentation will cover some bits of my earlier work and some of my thinking going forward. So, as I've indicated, the focus of the presentation would be tracking back a little bit and going forward. And I've structured this afternoon's presentation in terms of 5 areas. I would like to look at the epidemiology of infections in the area, models of developmental psychology on youth health, some samples of evidence, some guidelines for HIV prevention programs, and then some concluding thoughts. So let's begin with the first section on epidemiology of infections in Eastern Southern Africa as regarding children and adolescents. So what do we know thus far? And this slide is a slide that gives you a sense, a summary of the geographical picture of HIV prevalence in the region. We know Eastern and Southern Africa is the most highly infected region in the world. The epidemic in the region is generalized, and it's prevalent in adolescent girls and young women, and in what we term key populations: men who have sex with men, transgendered women, sex workers, prisoners, and people who inject drugs. All these groups are vulnerable to HIV infection. What we've seen thus far is that over the years, since 2010, we've seen there's improved availability of HIV testing services. And 2 out of every 10 people living with HIV are unaware of the status. And that's one of the major issues that we're still confronting in the region. Number of people living with HIV in the region continues to increase, but we've seen increases in access to antiretroviral treatment as well. We note in terms of the geography in the region, we've seen laws and cultural traditions vary between countries in Eastern and Southern Africa, and there are a number of ingrained structural and legal barriers to HIV prevention. So, despite the severity of the epidemic, we've seen some important strides made. in terms of access to treatment. We've seen viral suppression achieved in many countries. However, we still see areas in the region where it's difficult to access treatment, and HIV rates continue to increase. So, if we have to take a global look in terms of HIV prevention in the region, in the globe, we tend to notice that globally there are 1.7 million people inquired at HIV in 2019. And we've seen marked declines in incidence of HIV. And that's notable and that's important. And that's a result of the achievements that we've made over the past 4 decades or so. Although we see reductions in HIV infections and deaths in the region, still too many people are dying unnecessarily. One point to note, however, is that the fast-track targets for 2020 were not met in recently, and we have to improve on our targets if we are thinking about ending AIDS by 2030. If you take a step back and look at the sub-Saharan region versus the globe, and this is data that I've accessed from the Washington site on global burden of diseases. And if you have to look at the 2 graphs, at the bottom layer of the 2 graphs, you'll tend to notice that HIV continues to be a major burden in sub-Saharan Africa, for adolescent girls particularly. And when one compares that with global statistics, it's a shudder to think that we have such a major task on our hands. We've seen that in terms of comparing males and females, the burden is much higher for men. Sorry, for women. And in terms of global statistics, we've seen in the area of adolescence that we tend to find that vulnerabilities in northern and western countries seem to be focused in other areas. So let's go back to the Eastern and Southern African region and what the recent data tells us. Generally, adolescent girls and young women in Eastern and Southern Africa have a higher rate of infections compared to adolescent boys and young men. And we've seen that although we've seen declines in new infections amongst girls and boys, these declines are not going down fast enough. We also know there are country, age, and gender criteria that relates to these declines. If we look at the distribution of new HIV infections by population across sub-Saharan Africa, we see that new infections occur amongst females between 15 to 24 years. And we see the majority or the major part of the population distribution concentrates on females in the 15 to 24 year age range. So we have a young population of women, which is increasing, and we have higher rates of HIV in the region. Girls also have a higher prevalence of HIV than boys in Eastern and Southern Africa. In 2020, there was 1.5 million people who were living with HIV amongst girls 15 to 24 years. And this is more than 2 times higher than boys in the same age range. In 2020, we had 710,000 people living with HIV in the 10 to 19 age category. And this rate was higher than boys in the same age range. So the majority of people living with HIV occur amongst adolescent girls, age 15 years and older. If we look at mortality rates in the region, and if you look at the second graph, you'll tend to notice that, well, if you begin with the first graph, you'll tend to notice declines in age-related deaths, and that's mainly due to expansion of art programs since 2010. However, we've seen more rapid declines amongst adolescent girls and young women. However, we are seeing a tapering off of the graph for young males, and this is worrying. It seems that young men are more at risk of dying from HIV, and that could be due to men testing later, being put on treatment later, and non-adherence. So it's a worry for us that young men are not accessing HIV services. If one looks at new infections in the region, and we compare this in terms of age categories, in terms of middle and older adolescents, 15 to 19 years and 20 to 24 years, we see country differentiations occurring. And these differentiations or differences in patterns could be due to underlying issues of gender inequalities, poverty, and dependence on men, including high school dropouts as well. So it's important that when we think about HIV programming, that we consider geographical HIV incidence rates. In places with high HIV prevalence, women who experience interpartner violence are more than 50% more likely to acquire HIV. And this is in part because women who are physically or sexually abused by their partners are more likely to experience mental health issues, more likely to misuse alcohol, and less likely to have control over sexual decision-making, all of which increase propensity for HIV risk. We've seen the recent South African data showing that women living with HIV have higher levels of IPV. So that could explain some of the patterns that we've seen. A key area of concern for intervening with adolescents and young people in the region is focusing on young key populations. And we define young key populations as young people between the ages of 15 to 24 years who share the same characteristics as key populations. Those are sex workers, gay men who have sex with other men, transgendered people, people who inject drugs, and prisoners. However, one of the major limitations of intervening or challenges of intervening in young key populations is that we have limited data on HIV incidence rates and behavioral data regarding access to services. And so what we can do pretty much is infer data from adult populations. And this is not ideal. However, if we look at the graph, we tend to notice that, that HIV prevalence is higher, for instance, in the sex worker population and in other categories of key populations. In terms of research, we need to have more size estimation studies of key populations and young key populations in the region. We need to have denominators in order to be able to understand how we can devote resources and target interventions to young key populations. There is some work being done in the region. Herder's worked with the SADC secretariats and with intervention organizations in the region to try to estimate populations in this category for HIV services. what we tend to see in the adult-based data is, though, that key populations at a much higher risk than their age-matched non-peers in terms of HIV incidence and prevalence. Despite widespread HIV prevention messages in schools and media campaigns, evidence shows that HIV-related knowledge amongst adolescents is low. For example, only 36.1% of young people aged 15 to 24 had correct knowledge about sexual transmission of HIV and rejection of major misconceptions about HIV. This is from the HSRC data. Secondly, we've seen that reported condom use with non-marital partners remains well below 50% in some countries in Eastern and Southern Africa. In 2017, in South Africa, it was estimated that 67% of young men aged 15 to 24 years reported condoms during the last sexual encounter. This was down from previous surveys. In general, young men aged 15 to 24 are more likely than their female counterparts to have more than one sexual partner. For example, in Zambia and Kenya, young men were more likely than young women to report having multiple sexual partners. So despite the high prevalence of HIV infections amongst adolescents and young adults, uptake of HIV counseling and testing services in this population remains suboptimal. We know that HIV testing rates are low amongst adolescent girls and young men. So it's becoming an urgent priority for children and adolescents living with HIV to access treatment, and those are undiagnosed to seek an HIV test. Here I present some data on condom use with a non-regular sex partner. You can see the data here is highly variable, with condom use amongst young men more likely to occur than amongst young women. And this is linked to gender power imbalances in negotiation safe sex. So thus far, the picture for the ESA region is mixed. We've seen declines in new infections, and that's a positive sign. We've seen declines in AIDS-related deaths. Obviously, there's country variations. However, progress has been far too slow, especially for adolescent girls and young women and for young key populations. And we are concerned about the AIDS-related deaths in young men. So this first section has presented data in the region on HIV prevalence and incidence rates amongst adolescent girls and young women and their partners, including young key populations. And one has to say that in terms of the data being presented, obviously there's country variations and sub-variations within countries regarding HIV incidence rates. There are data gaps that remain in the region in terms of young key populations. There is more need for us to be able to tailor intervention programs to sub-regions and district level interventions in order for us to be more effective. So the second part of the presentation, I have a slide that talks to developmental trajectories in adolescents and young people. And what I want to point out here is that when we're thinking about adolescent and young people, we need to consider developmental transitions. And we need to think about biological, psychological, and social changes occurring in this group. So I present two models here. The first model is a model by Sawyer, which looks at a proximal distal diagram of risk, social vulnerabilities and risk relating to health outcomes. And if you look on the x-axis for the first graph, you'll tend to notice that we begin with the macro determinants of health and we progress towards more proximal indicators for health, influences for health, and health outcomes. And then across, we tend to look at the kind of development transitions from early childhood to adulthood. In terms of the second illustration, this is more of a kind of a telescopic presentation. And here we're looking at kind of temporal transitions to give you a kind of a life course perspective on risk and vulnerability. So these conceptual models are useful in us being able to think through risk and vulnerability amongst adolescents. Obviously, when we talk about adverse contexts, the social and structural vulnerabilities, for instance, lack of education, poverty, gender inequality, discriminatory policies and legal frameworks tend to heighten exposure of young people to risk and vulnerability. And they disrupt typical trajectories of development and create barriers to successfully negotiating pathways of risk. In this section, I would like to talk through some samples of evidence from work that I've conducted over the years and provide you with some snapshots of some pieces of research and carry this through in terms of thinking about more broad-term interventions. So I categorize my work over the past 25 years into three, if you would call it, epistemological strands of research. And the first part of this research, I focused on delineating risk mechanisms or psychosocial risk mechanisms to understand HIV risk. And more particularly, I'm focusing on risk and protective mechanisms. And this has been explored through cross-sectional studies, longitudinal studies, networking analysis, and intervention type analysis. And it's related to particular partnerships and funders and new research that's emerging. The second strand focuses on in-depth qualitative studies. And here I've tended to look at understanding social processes, social identity processes, risk formation processes, and focused on kind of theoretical and conceptual analysis, discursive ethnographic studies, and here trying to understand how the social impacts on behaviors. The third piece or strand of work is focused on reviews of policy reviews and program reviews and providing a more kind of critical stand-back approach to developments in the fields. Obviously, these three areas have been interlinked, and in interlinking of these streams of research, the point here has been trying to solve this complex puzzle of how we improve the sexual health for young people within the context of adversity. And these strands of research have been linked to knowledge dissemination activities at an academic level and at a broader level in terms of policy dialogues, programming. So let's look at the first strand, and you can see the blue illustration that denotes the first strand of studies. And this was a study that I did with colleagues in the department a number of years ago. And the point I want to illustrate here is the clustering effect of risk. And we undertook a study looking at school connectedness, which is a psychosocial construct, and its links to risk behaviors. in South Africa. And if we look at school connectedness, it's defined as the extent to which students feel personally accepted, respected in their school environment. And the hypothesis for the study was that strong perceptions of school connectedness will more likely lead to lower risk, health risk behaviors. And included in the health risk behaviors were lower levels of violence, sexual risk, suicidal ideation. And it was a pilot study and a relatively small sample of school-going students. And in the study, we found, not surprisingly, that low levels of emotional belonging attachment or low levels of social cohesion to a school context was associated with increased violence and substance abuse, lower ranging age of first sex, and use of drug and alcohol during sexual encounters, including suicidal thoughts. So the point here that the study was making was that one should not be looking at one risk outcome, but rather be looking at the risk profile. And this work suggests that if we are to intervene in one domain, and a large and broad domain that could be called improving school connectedness or social cohesion, then we may be able to impact on multiple risk outcomes. Obviously, more research is required on looking at predictors and multiple outcomes and pathways to multiple HIV outcomes in population-based research. And the point here is that understanding the clustering effects of risk and how they operate in adverse contexts possibly gives us some signs for how we can think about HIV prevention programming. Obviously, for this piece of work, the sample size is small, and this was cross-sectional data. But the psychometric instruments for the study were quite strong. So that provided us grounding for further work. One looks at a next level in terms of quantitative studies, and a study I pick out here that I worked with in more recent times is looking at micro and macro system processes linked to sexual risk, and this is premised on Bronfenbrenner's theory on systems and multiple systems having impacts on outcomes. And in this study here, we looked at singular isolated systems and impacts on sexual risk, but also on other kind of adolescent type risks. We hypothesized that individual proximal and distal factors associated with sexual risk outcomes. And this study was conducted over 2 periods. We had a baseline study and a follow-up a year later. And I present the regression models here. And what we see is that that factors related to risk occur in a complexity, which means that we need to think about multifaceted interventions for HIV prevention. We are undertaking further analysis on the longitudinal data, and we found that high level of teacher support at time 1 was associated with lower levels of substance abuse at time 2. However, this finding did not hold for sexual risk. So the latter non-significant finding could be attributed possibly to previous research showing that teacher challenges in implementing sexuality educations in schools. However, this research also begs the question, do components of systematic interventions work, how they interact with each other? So if we're having interventions at the individual, family, peer level, do these interventions impact in a kind of collective manner to buffer or mitigate risk outcomes. I suppose we need more intensive research to understand the interacting components of various types of interventions. Another question we could ask is, in communities with high levels of social cohesion, would they be able to buffer, for instance, poor parenting practices? Or would children growing up in adverse environments be relatively insulated from the negative effects of strong parental or family networks? So obviously more work needs to be done in teasing out micro and mesosystem processes and its links to HIV risk. A positive aspect of the study is allowing us to look at systematic and longitudinal analysis and working with more reliable measures. One of the down points of this kind of work, and it's demonstrated in a number of studies, is the ability to link these psychosocial indicators to biological outcomes. Okay, so move on a little bit more at pace. This study we conducted quite recently as well, and here we were looking at a protective mechanism called resilience. And resilience is adapting in the face of adversity. And here we wanted to understand how people have capacities to produce resilience in context of adversity. And resilience here could be construed as individual, relational, and contextual factors that foster positive outcomes in young people. And you would notice that in this networking analysis, one of the main points that we point to here is that resilience is a complex interacting network with country-specific profiles. For example, in the South African arm of the study, we were able to show that education was valued as an important resilience mechanism and linked to upward life trajectory. And that's possibly, and we've seen that in other work in South Africa where we found relationships between HIV risk, low HIV risk, and keeping young girls in schools. However, in other contexts, we found that personal freedom was a more important resilience mechanism, or community values being valued as a resilience mechanism. So this study gives us empirical evidence from multiple countries on the interplay of social ecological resources, either at peer, caregiver, or community level, and how that impacts adolescent resilience. Across the countries, however, we found that caregiver support appears to be most central in adolescent resilience. Further resilient interventions may be able to apply this network type of approach to identify important contextual resources to foster resilience. The previous studies that talked about looked at psychosocial aspects of HIV risk. More recently, we've engaged with HIV prevention activities and what we term combination prevention activities in terms of the DREAMS programming. DREAMS aims to reduce HIV incidence amongst adolescent girls and young women in 10 countries by 25% in its first programming year. In this study, we've assessed the associations between HIV risk and interventions, and a constellation of DREAMS interventions at a particular site in KZN. And if you look at the forest plots and the tables, you will notice that when we created an index for a number of exposures to DREAMS interventions, we found that more than or 3 or more exposures was related to increase in HIV testing behaviors, condom use strategies, and uptake in art. So here we've provided some evidence for layered interventions and why layered interventions and combination prevention interventions are important for HIV prevention. obviously, we need to take this analysis, look at the longitudinal effects of these outcomes, the more temporal effects of interventions in terms of maintaining low HIV risk. We require more research to understand how exposure was measured and the quality of that exposure in relation to HIV interventions. So the first part of the studies, the snapshot of studies that I've chosen to illustrate some fundamental concepts in psychosocial aspects of risk are important to HIV prevention interventions. And I'll pick this up later on. The second strand of research has been qualitative work focusing on adolescent boys and young women. And part of this work originated from research I did in my PhD between 2004 and 2008, looking at discursive identities and focusing particularly in terms of identities and sexual risk practice within systems of ideological and material formations within the gender order. So I was interested in how social and normative practices impacts on identities and how these identities relate to sexual risk. My early work looked at hegemonic masculine identities as sites for contestation and struggle in terms of sexual risk, and I point to some research about how public and private identities struggle for dominance within the hegemonic masculine script, and what that means for HIV risk. We've also undertaken work with young women and HIV risk, looking at ethnographic types of research, and here looking at the kind of social issues and looking at social context in terms of poverty, patriarchy, and how that's impacted on HIV risk. So I think the point about these studies is that a deeper dive into identity formation processes and understanding how identity links to social practices is important for informing HIV prevention interventions. Contextual issues, to tailoring interventions, to understanding risk formation practices in particular contexts. Myself and a postdoc student are working on a 10-year review on understanding how risk reduction interventions, or for young men in particular in sub-Saharan Africa, is linked to HIV risk mitigation as part of the kind of a sub-theme of masculinity work. So I think the important point here is that we need to have conceptual insights to go beyond individualized interventions and to focus on gender relations, which seems to be the substrate for well thought through HIV programs. The third strand of research and analysis has focused on country laws and programming and policy in the region, and where we've seen policy developments and failures. As you would have noticed from previous slides, we've tended to focus on downstream and proximal factors. And the advantage of downstream and proximal factors is that it's close to actual behaviors. However, we tend to notice that in context of adversity, structural and macro factors are directly and indirectly linked to risk outcomes. And there's been a lot written about structural drivers of HIV, with many developments on policy, protocols, on minimum service packages, and on guides to HIV programming in Eastern Southern African region. So we know that the region is highly intensive in terms of policy and a programming environment. However, these developments suffer on two fronts. In ESA, we see, although we see it's a highly intensive environment of policy action, human rights violations continue to hinder the HIV response. And there's a lack of political will accompanied by poor implementation of policies and programs. Where there's progressive legislation that occurs, like for instance, legislation policies to deal with sexual and gender-based violence, for example, in South Africa, we see high levels and unacceptable levels of violation of women and children's rights. So that's a major concern for HIV programming in the region. And it impacts on key populations in terms of access to services, adolescent girls and young women, and LGBTI communities. This is an illustration of the discriminatory and restrictive laws in countries in the region. And you can see the many challenges that we have in intervening in the legal and policy environment. Criminalization of sex work is an issue. Consenting practices for adolescents to access HIV testing services, laws criminalizing the transmission and non-disclosure of HIV. So there's a lot of work that needs to be done to change this picture. And it's good to see that in the expanded UN targets to 2025, that there is now a target on shifting and a monitoring mechanism to look at revising these discriminatory and punitive laws. Here as well, we're talking about discrimination, discriminatory attitudes towards young people living with HIV in the region. And we tend to see that in Eastern and Southern Africa, while there's been progress, it's uneven. And in countries like Madagascar and Ethiopia find higher rates of discriminatory attitudes. I've made this point about the inconsistencies in age of consent policies, and it's important that we harmonize international and regional human rights laws and commitments. I'm moving through the slides at a much faster pace now. In the region, we've noticed disruptions because of COVID to HIV and SRH programs, and this has set back the region in terms of services, and it's been a concern over the past 2 years. And HIV prevention programming requires more resources enabled to pick up where it's left off prior to COVID-19. Gaps in HIV programming, I've indicated we need to look at stigma and discrimination reduction strategies, sensitization of laws and law enforcement agents to the needs and plights of of key populations, legal literacy, extension of HIV legal services to people living with HIV, and monitoring and reforming laws and policies, which is key to the region. And some of this work is based on global fund assessments undertaken by HERD on particularly in terms of human rights assessments in some of the countries in Africa. I want to move on quickly to the last part of this presentation and try to make the presentation complete within the time limits. So what can we think about in terms of guides and insights of policy and programming? Well, we need to look at HIV prevention as a socially constructed and programmatic response that's tailored to particular contexts, and we need localized and high quality data to enable that planning. What we've seen thus far in terms of biomedical interventions, the major issue is adherence, and that's because there's a human element that's involved in HIV prevention. It becomes a problem. So it means that we can't rely on biomedical interventions alone to be able to effectively intervene. These are some of the common drivers of HIV infections amongst adolescent girls and young women, and we're familiar with this literature in terms of the key drivers: age disparate sex, high school dropouts, interpartner violence, child marriages, so low levels of HIV testing, and some of the intervention and programmatic responses. What I'd like to get to is this illustration here, which gives you an idea of how we can amass the evidence that I've talked about thus far, and to be able to put this into some sort of coherent programming. And if one looks at this at the figure 7, one tends to understand the kind of combination level prevention interventions that's required in terms of core packages, the dimensions of change, the types of HIV prevention outcomes that one is looking at, and the impacts. So an options menu like this should be implemented at countries and district levels in terms of program packages. One is stating that there should be a standard assembly of HIV services delivered in all settings. However, the level of intensity should be aligned to incidence levels, and that's what table 1 is indicating. Decisions on programming has to be based on local data. Local data is really important, and the context and the profile of the population in a particular context. So, for example, in settings where social grants and access to education is already high, focusing the HIV response solely on cash transfers may not add value. So one has to look at what interventions are currently occurring in context. Similarly, interpersonal communication addressing specific risk factors such as multiple sexual partners or age disparate partnerships will be most relevant in contexts where HIV incidence is very high. For this to occur, we need modeling to occur of HIV incidence at subnational level for adolescent girls and young women in particular age bands. You can use HIV prevalence as a proxy. We also need to look at sub-regional variations, and I mean here at a granular level. So for example, if a region does not show high HIV incidence, it may be specific locations like transit route cities, mining areas that may have higher incidence. So we really need to get down at a granular level to understand patterns of the epidemic in order to tailor interventions of packages can be applied in different areas depending on intensity and levels of incidence. Again, similarly, a PrEP outreach should be a high intensity activity and should be implemented in settings where there's high levels of incidence. So policy and structural interventions that we're talking about in this mix of programming has to be standard and part of a package. However, it needs to be considered in terms of local implementation of HIV programs. For instance, if you want to design programs, particular types of components of programs, we need to think about, for example, a condom promotion program. We need to look at clear marketing strategies, distribution plans. We need to look at issues of removing supply side constraints, understanding population demands, product choice, and delivery platforms. And this should occur within the larger context of ongoing social and behavior change programs. And this is, again, an illustration of delivering a condom promotion intervention and undertaking analysis at the behavioral and structural level in order to inform different components of the program in terms of the type of priority population, the service delivery mechanism, and the costing and other considerations. When we talk about intensive social and behavioral programs, we need to pay attention to the type of activities. They could range from individual to more community-based activities and media type activities. And the focus here on these behavior change programs is to shift social and gender norms. And we've seen innovative examples of multimedia campaigns in communities, and I'll provide some examples of programs, evidence-based programs that have shown effects on changing behaviors, including the Stepping Stones program, its expansion into the Share Trial, the SASA program in Uganda, and the Love Life programs. Success factors: men and women need to be part of the intervention. We need to have a theory of change, knowledge on HIV risk. We need to consider issues of self-efficacy, community mobilization for normative change, as well as to have well-defined criteria to address issues such as power imbalances. We need to look at interventions which are participatory, and we need to consider how we can scale up delivery platforms and monitor quality and delivery of these interventions. It's an example of community mobilization campaigns and multimedia campaigns that have shown promise in the region. So I want to get to the point of thinking more broadly about HIV prevention programming in light of the kind of array of issues that I've talked about thus far at a kind of micro level, meso level, and at a structural level. And while one holds that aside, it's important to know that there are ongoing conversations in the region regarding how do we frame the HIV and more broadly the sexual and reproductive health response within the universal health coverage agenda. And we are seeing countries presently formulating essential health benefit packages in terms of what constitutes these packages, which populations are being covered, and at what financial cost. And this occurs in a context where we're seeing dwindling of money for HIV programming, a large part of the funding going for treatment, more pressures for country level allocations to HIV programming as opposed to external donor-led allocations. And we've seen a limited amount of money being allocated for HIV prevention activities. We also noticed in the region increasing out-of-pocket costs for healthcare services. And there is a concern that when we talk about more broadly about universal health coverage and a formulation of these health benefits packages, that marginalized and vulnerable populations will be excluded and key SRH services may be left out. And as well, the prevention activities pushed off to the margins. So these are concerns that we are faced with when we think about HIV prevention. And it's important to note that there are also opportunities. The opportunities is for us not to lose the research and policy interventions that are ongoing and use it as an opportunity to strengthen investments in HIV and SRH programming for different communities of young people. We've seen multi-sectoral programming show some promise in tackling social and structural drivers of HIV. And we need to focus on promoting combination prevention initiatives, particularly initiatives that focus on human rights, reducing human rights barriers to accessing HIV and SRH services, and using an equity lens to the universal health coverage agenda. And the question is, how can we make programming efforts more contextually specific and orientated to the needs of young people? And that's an overriding theme in this presentation. And a related theme is, how can we bring evidence to inform more tailored HIV programming efforts? And there are gaps in evidence at a country level and at a sub-regional level in understanding patterns of the epidemic. Very importantly, another arm to the prevention agenda is to bolster the capacity of civil society, push for investments in human rights and social programming, reducing stigma, shifting harmful social norms, and promoting the inclusion of sexually and diverse gender minorities. It's important to note that ending the epidemic for young people requires more resources, further global commitments, political will, and an emphasis on people-centered systems. Thank you.
Ladies and gentlemen, I can hear your real and virtual applause from wherever you are. The challenge of encapsulating a lifetime of work in a single public lecture. The lecture reminded me of the complexities of data generation and the need for estimations and multi-level models in this critical topic of HIV prevalence, risk profiles, and prevention. Professor Govender's wide-ranging research endeavors have contributed significantly to knowledge generation on the socio-economic aspects of public health, especially the African HIV and AIDS pandemic. His research output has provided multidimensional perspectives on intervention strategies that can be adopted by other researchers and policymakers in the prevention of HIV infections among the youth in our region. This quality research by Professor Govender invariably contributes to the credibility and esteem of our institution as the premier university of African scholarship. On behalf of the College of Law and Management Studies, it is my honor to deliver the vote of thanks. I would like to begin by thanking each and every colleague, student, friend, and the family of Professor Govender for attending today. We acknowledge the contribution of the family in supporting Professor Govender in his journey. As a university, we value the role of loved ones who continues to support our staff as they make significant strides in progressing our university. I would like to thank Prof. Muller for introducing Prof. Govender and also acknowledge the following for their support and background work for this public lecture: the corporate relations team, the college PR team, the registrar's office, and ICS. Finally, and most importantly, congratulations once more to Professor Kaymarlin Govender on behalf of the College of Law and Management Studies. Thank you for your significant impact in academia. May you continue to inspire others to greatness. Colleagues, with these few words, I again thank you all for joining us today in supporting and congratulating Professor Govender, and I now draw this public lecture to a close. I wish you all a pleasant afternoon. Keep well.